So today's topic is hemodiafiltration. So I'll just go through the brief introduction of the topic. So the target audience is the dialysis personnel as well as the trainees. So you are a dialysis nurse or a dialysis personnel employed in the UK, and you are working in you are started to work in a hemodialysis unit abroad. So in most of the European cities use hemodiafiltration as a primary dialysis mode nowadays. So you are asked to start hemodiafiltration for a 70-year-old male who has come for dialysis, who is a chronic kidney disease stage 5 on dialysis. So you should understand, you should know what is hemodiafiltration. You should understand the principles of hemodiafiltration. So we'll go through the principles of hemodiafiltration. You have to see what is the evidence for doing a hemodiafiltration. You should understand the technical aspects of hemodiafiltration. So the principles of dialysis. So as you know, there are two primary modalities of solute as well as solute removal in renal replacement therapies. One is diffusion, the other one is convection. So diffusion, you are all familiar. You are taking the blood from the patient and it runs through the hemodialysis cartridge. And at one end, there is a dialysis inflow, and the other end, there is an outflow of the dialysis. And these are the low molecular weight solutes, and these are the middle molecular weight solutes. And the water is represented by the blue dots. So what happens in diffusion is there is a movement of the solute compartments from a region of higher concentration to a region of lower concentration across a concentration gradient. And this is primarily due to the kinetic energy of the molecules. And the smaller molecules, being small, they have a lot of kinetic energy than the middle molecules. And as a result, the movement of the small molecules will be faster when you compare it to the middle molecules. So there will be this movement of the small molecular weight substances across the dialysis membrane into the dialysis solution is what is known as diffusion. On the other hand, in convection, what happens is that there is a flow, the blood is taken through the convection, the hemofilter. And what happens is that this membrane is actually a very high flux membrane, which have a very high mass transfer area coefficient. And as a result, it is highly permeable to solutes. So there will be movement of the solute as well as there will be movement of the middle molecules. So there is no dialysis solution which actually flows in this sort of hemofilter, and the ultrafiltrate collects and it is removed from the patient's body. And to compensate for the excess amount of the fluid that is removed, you have to run in a substitution fluid. So you need to have a replacement fluid in hemofiltration. So when you combine both these modalities together, we come to what is known as a hemodiafiltration. So in hemodialysis, the membrane is nowadays they use a high flux membrane, and there will be diffusion. The principle that is used is diffusion. And in hemofiltration, the principle that is used is convection. So when you combine both these modalities, you get hemodiafiltration. And you have to run in a substitution fluid. And the substitution fluid is run either into the post-dilution mode, where you enter the blood flow back into the patient, or you can run it pre-dilution. So this is what happens in hemodiafiltration. So you are combining the convection as well as diffusive properties so that you get a good solute clearance. So the infusion modalities can be post-dilution, where you infuse substitution fluid into the blood, which is returning back into the patient, or you can use it in a pre-dilution mode, where the substitution fluid enters a hemodiafilter. Or you can have a mixed dilution method, where part of the fluid goes into the pre-dilution mode and the part goes into the post-dilution mode. And on the other, there are other techniques which have come, which is known as a mid-dilution. In mid-dilution, you infuse the replacement fluid into the midpoint of the hemodiafilter. So the teaching points with regards to the principles are: uremic retention solutes are traditionally classified into small water-soluble compounds, middle molecules, and protein-bound compounds. The diffusion primarily results in the removal of small water-soluble compounds, whereas the middle molecules are best removed by convection. So when you combine both these modalities, the removal of the middle molecules is markedly enhanced. So this removal of the middle molecules is thought to increase survival of these patients on this particular form of renal replacement therapy. Now, what is evidence of for doing a hemodiafiltration? Why do you want to do hemodiafiltration? All this renewed interest with regards to hemodiafiltration came with the publication of this trial, which is known as a CONVINCE trial. So this CONVINCE trial was published in 2023. So it was done in 8 European countries. It was a prospective randomized controlled trial. So the patients, around 1,360 patients, were classified to either undergo high dose hemodiafiltration or a high flux hemodialysis. High flux hemodialysis is what is generally done abroad, not in India, whereas it is done in most of the European cities as well, European centers, as well as in US, where you give a ultrafiltration coefficient of more than 12 milliliter per hour per millimeter of mercury, or with a beta 2 microglobulin clearance, which is greater than 20 ml per minute. So they were randomized into 2 groups. So lot of patients underwent high dose hemodiafiltration and the remainder underwent high flux hemodialysis, around equal, and they analyzed the patient mortality. So death from any cause was analyzed at the end of 3 to 5 years, and it is found that the use of hemodiafiltration demonstrated significant survival benefit over high flux dialysis, although the cardiovascular outcomes were similar. So the survival benefit was much more when when the patients underwent hemodiafiltration. So the hemodiafiltration, they underwent around 3 sessions per week, and the target convective clearance was kept at 23 liters per session, which we'll come to it later. So now coming to the technical aspects. Now, what is commonly done is known as online hemodiafiltration. It is also abbreviated as OLHDF. OL refers to online. So online hemodiafiltration. So one of the first requirement for a patient to undergo online hemodiafiltration is you should understand what is known as back filtration. So this is a dialysis cartridge, and the blood comes into the dialysis cartridge, and this is a blood compartment, and this is a dialysate compartment. And the pressure, there will be the pressure difference between the two compartments will be maxima at the start of the blood compartment, and in general, as there will be movement of the water across into the dialysis compartment, the pressure in the blood compartment decreases, and there will be gradual loss of the transmembrane pressure. So, however, this transmembrane pressure is generally maintained in a patient who is undergoing a low flux hemodialysis. So, this back filtration generally doesn't happen to a greater degree in a low flux hemodialysis. Whereas in a patient who is undergoing a high flux dialyser, as in which is used in a hemodiafilter, there will be, because of the membrane is highly permeable to water, there will be a very drastic drop in the transmembrane pressure. So by the time the blood enters, goes at the end of the hemodiafilter, what happens is that there will be back filtration of the fluid from the dialysate fluid from the dialysis compartment into the blood compartment. So this is known as back filtration. So the back filtration is a movement of the dialysate fluid from the dialysis compartment into the blood compartment, and this dialysate fluid goes back into the patient. So the importance of this concept of back filtration is that your dialysis solution must be really of great quality. So the bacterial count should be totally zero, and the endotoxin level should be undetectable. For this sort of dialysis solution is known as an ultra pure dialysate. Otherwise, the patient will have a lot of complications, like the patient can develop sepsis, the patient can develop endotoxemia, and the whole outcome measures will be drastically reduced. So in hemodiafiltration, you use ultra pure dialysis fluid where the endotoxin level is less than 0.03 and the colony forming unit is less than 0.1. And there are no tests which are able to detect all these. These are in general undetectable by the standard tests. So you cannot demonstrate an endotoxin, you cannot demonstrate a bacterial colony count in this ultra pure water. So such a high degree of sterility of the dialysis fluid is required if you want to do this procedure. So as I already told, there will be this the principle that is used is hemodiafiltration. So you have to run in the dialysis solution, you are taking out the fluid, and you are running in a substitution fluid. So this is a how to run in the substitution fluid. That is the next question. So in continuous renal replacement therapies, as you know, the manufacturer often gives you bags. So the bags contain sterile dialysate, and the sterile dialysate often substitutes as a dialysis solution as well as a substitution fluid in majority of the continuous renal replacement therapies. However, these methods are limited by the amount of the fluid that can be removed by ultrafiltrate. So the bags, you should run in lot of bags to produce a desired level of ultrafiltration or the convective clearance that is required if you want to do a hemodiafiltration. So for this is a major limitation if you use preformed dialysis solution in preformed bags. So the solution for this problem is to generate the dialysis solution by the machine itself. So the generation of the dialysis solution by the machine itself is known as online hemodiafiltration. So this technique is known as online hemodiafiltration. And there are two methods by which you can use this. So the standard dialysis solution from the machine is then taken to another filter. This another filter is a good bacteria filter, and it is also functions as an endotoxin filter. So the dialysis solution is prepared by the machine from the concentrate and the RO water, and the dialysis solution is run through the first filter, and the first filter purifies the solution, and ultra pure water goes into the hemodiafilter cartridge, and a part of the ultra pure water goes into the next pump. This is an infusate pump, and the infusate pump, post infusate pump, there is another filter which clears dialysis solution, and this is directly infused into the patient's blood. The point to be noted is that the solution directly goes into the patient's blood. So the solution should be of extra good quality. So it should be the standard of care should be that that is normally seen in intravenous saline preparations. So this should be the standard of the solution. So the second technique is the standard dialysis solution is generated by the machine. Again, here the filter is located pre-pump, pre-infusate fluid. Whatever be the method, after the first filter, when the infusate is delivered back into the patient's blood, it has to go through another filter. That is the most important thing that you have to remember. So the different manufacturers use either one of these techniques. So in most of the techniques, the purified water as well as a dialysis solution is generated, and the dialysis fluid comes in, and the dialysis fluid goes through the first filter, and it goes into the second filter. And some machines utilize two filters prior to the infusate pump. Part of the solution goes into the dialyzer, and the second part goes directly into the patient's blood. And the advantages of this online hemodiafiltration is that you can use this solution for pre-dilution. You can use this solution for priming. You can use this for flushing, and you can use this solution for washback. So you can considerably cut down the cost for all these procedures. And there are software techniques, things which are integrated into the machine, which will automate most of these processes. So the processes of priming, flushing, washback, everything is automated. So you can you can cut down on the preparation time of the patient as well. So during online hemodiafiltration, up to 20 liters per hour of the dialysis fluid can be infused directly into the bloodstream. The infusion fluid must be free of chemical contaminants, sterile and pyrogen free. And the infusion fluid is prepared with a dialysis machine that has been validated to produce sterile and pyrogen fluid. So these are the things that you have to remember with regards to the online hemodiafiltration. Now coming to the membrane. So there are different sorts of membranes which are available. So the major things which have to, the major parameters that you have to think with regards to the membrane as one is with regards to its diffusion. What is a membrane capable of diffusing the solutes? This is a hemodialysis part of it. Now coming to the convection, this is a hemofiltration part of it. You have to know about the membrane sieving as well as ultrafiltration. In general, In general, the membranes used for hemodiafiltration are synthetic polymers. They are microporous and hydrophobic, hydrophilic properties are there. They have got high hydraulic permeability. They have got a high sieving properties, and the diameter is usually about 200 micrometer, and the wall thickness is about 30 micrometer. And they are primarily used for ultrafiltration and hemodiafiltration. So these are in general the qualities of the membrane that are used. So the filters for hemodiafiltration should be defined as hemodiafilters, and the mass transfer area coefficient should be more than 1000. And in general, you select a membrane with a high KUF, and the ultrafiltration coefficient should be more than 30 ml per hour per millimeter of mercury per meter square. So this is in general the characteristics of the membrane that are selected for hemodiafiltration. Now coming to the online hemodiafiltration machines which are available. So there are different manufacturers give different machines. One is Baxter. Baxter has got an Artist dialysis machine. Braun has got a Dialog Plus Hemo SDF machine. And Fresenius has got the 5008 and 5008S series of machines. Then you have, in all these machines, there is a cartridge system. So if you see the front of the dialysis machine, normally it will have two pumps, and the additional three pumps will be there if you are using a single line hemodiafiltration. So there will be a blood pump and there will be an infuser pump, and there will be a cartridge which it can be connected into the machine. So in general, this is a cartridge system. And if you look at the back of the machine, there is two ultrafilter cartridges. The cartridges that we had discussed earlier, which are meant to generate ultra pure water. Now, this is a machine which is manufactured by Nipro. It is known as Surdial. This is a hemodiafiltration machine. These are the technical features of the Surdial machine. I am in no way campaigning for this Nipro machine, but this is when I went through the literature, this is one which was easily accessible. That is why I am showing this. So the technical features, if you look at the technical features of this machine, it shows a blood pump flow range of around from 10 to 60 ml per minute. Dialysate flow, which you can keep from 100 to 800 ml per minute. You can select the dialysate flow modality. Then substitution fluid infusion can be manual or automatic. And the substitution flow rates can range from 10 to 500 ml per minute. Then substitution fluid delivery can be post-dilution or pre-dilution. You can use online priming, rinsing, and IV bolus. Everything can be done automated by the machine. There is an option for blood access monitoring. There is online clearance monitoring. These are in general, the technical features of the machine. As a dialysis personnel, you will be interested in all these technical details. Now, this is a screenshot of the membrane. So this membrane is running in a pre-dilution mode. Then there will be the treatment modalities. The remaining time is shown. The ultrafiltration goal that is kept is targeted is kept. The ultrafiltration rate, then the ultrafiltration volume is that is shown. Substitution fluid rate and the substitution fluid volume is also can be seen on the screen. Now, these monitors measure the arterial line monitors, venous pressure monitors, transmembrane pressure is monitored, conductivity, the bicarbonate conductivity as well as the temperature. Everything is monitored here. And online heparin flow is also monitored. Now there are monitors which detect the ultrafiltration volume, the ultrafiltration rate, and the time, everything, the modalities of dialysis, everything is monitored in this procedure. Now you have to understand the concept regarding filtration fraction. This is important in hemodiafiltration. So what is filtration fraction? So filtration fraction, this is a hemodialysis cartridge. The blood comes in this through this blood inlet, and the blood goes through the blood outlet, and water is removed. So filtration fraction is the amount of ultrafiltrate that is removed, or the amount of the fluid that is removed as a result of convection, divided by the plasma flow rate. The plasma flow rate can be calculated from the blood flow rate. So from the blood flow rate, you can calculate the plasma flow rate when you take into account the hematocrit and the total plasma proteins. So it is actually the amount of the ultrafiltrate that is pulled out from the patient's body divided by the plasma flow rate. This is in general the filtration fraction. This is how you calculate the filtration fraction. Now, why is filtration fraction important? Now, filtration fraction is important because as you remove more fluid as a result of this procedure, you are removing actually plasma water from the blood. So the blood becomes concentrated. So when the blood becomes concentrated, there will be increase in the osmolality of the blood. The plasma concentration, the hematocrit increases. This leads to what is known as membrane fouling. So after some time, what will happen is that the plasma, because the concentration of the plasma proteins increases, the plasma proteins get deposited on the plasma membrane. And this process is known as membrane fouling. And once there is membrane fouling, the further filtration of the solutes doesn't happen. And you will have to replace a filter, and there will be increased risk of clotting within the membrane. So in general, the thumb rule is that in post-dilution hemodiafiltration, you have to keep the filtration fraction less than 30% of the blood flow rate. So if the blood flow rate is 300 into 30 by 100, that will be around 90. So 90 will be should be the filtration fraction. So this is how you calculate the filtration fraction in post-dilution. So what is the typical ultrafiltration rates required to achieve convection rates? So when you are using post-dilution, if you are giving a blood flow of 350, you keep the ultrafiltration flow rate up to 70 when you want a filtration fraction of around 20%. And if you are keeping a filtration fraction of 30%, you can increase ultrafiltration rate to 90 ml per minute. So this is a concept of filtration fraction. And note that in majority of the machines, you are not directly setting that target of filtration fraction. Filtration fraction is automatically adjusted by the machine depending upon the ultrafiltration flow rate and the blood flow rate. So it is an automated adjustment by the machine. Now, with regards to anticoagulation. So the anticoagulation is almost similar to that what we use in standard hemodialysis. So you give a 25 to 50 international units per kilogram of bolus. You run a maintenance as an infusion, and the maintenance is infusion of unfractionated heparin is stopped around 30 to 60 minutes before the end of the treatment. Then you have to monitor the ACT, and the ACT levels should be monitored, and you have to modify the dose of heparin. Now, each unit will have their own protocol, and you have to follow the protocol. In general, the dose of anticoagulation that should be used for hemodiafiltration is approximately 15 to 20% of the standard dose that is required for the standard hemodialysis. Now, there are other alternative modalities which can be used in hemodiafiltration. One is low molecular weight heparin. So the benefits are it is easier to dose, and a single pre-dialysis dose is sufficient. It has more predictable kinetics, more reliable anticoagulant response, reduced risk of heparin-induced thrombocytopenia, less risk of hypertriglyceridemia. But there are certain drawbacks. The most important one is the cost of the thing. So enoxaparin can be administered as 100 anti-XA units per kilogram administered as a single bolus. So all these different anticoagulants can be used in hemodiafiltration as well. Now, how do you monitor the adequacy of online hemodiafiltration? So this is adequacy formula. This is for the pure, those who are really interested in knowing the adequacy of hemodiafiltration. So the total clearance KT is equal to KD. KD means the diffusive clearance. That is the component of the clearance achieved by hemodialysis plus Kc. Kc is clearance which is achieved by convective process into the dilution factor. So KD is calculated by a big formula which requires use of the dialysis mass transfer area coefficient, blood flow rate, dialysate flow rate. All these parameters are taken into consideration, and you calculate the KD. Now, Kc is calculated by looking at the values like the blood flow rate, the dialysate flow rate, the diffusive clearance, then the ultrafiltration flow rate, and the sieving coefficient. So from this, you can calculate KD and Kc. Now, the dilution factor is calculated from the plasma flow rate and the infused flow rate. And this is how you calculate the total clearance as a result of in online hemodiafiltration. Now, adequacy of dialysis can again be classified, can be calculated by looking at the diffusive clearance and the convective clearance. So in diffusive clearance, you calculate the KT over V. So this is for most practical purposes, you look at the diffusive clearance and the convective clearance. Now, diffuser clearance is calculated by the KT over V formula. The KT over V should be around 1.2 to 1.4 in each dialysis session, which is included in a thrice weekly dialysis session. And if you're looking at the convective clearance, you have to look at a target of 23 liters of fluid should be removed in every session, or 70 liters per week on a thrice weekly schedule. And the main factors which influence the convective clearance are almost the same as in dialysis. One is the blood flow rate. You can go up to 400 ml per minute, or if the fistula is really good with no hemodynamic compromise, you can go up to 450 ml per minute. And often you require a 14 gauge or a 15 gauge needle to achieve such good blood flow. And you should have a very good vascular access. That is a prerequisite for putting a patient on a hemodiafilter. Now, the second thing is that the choice of the hemodiafilter. And the diafilter should be approximately 200 to micrometer in diameter. It should be around it should have a surface area of ideally 2 meters square and a mass transfer area coefficient more than 1000 and an ultrafiltration coefficient ideally above 55 ml per millimeter mercury per hour. And you have to think you have to be concerned about the dialysis time. So if the blood flow is high and if you are selecting a good hemodiafilter and if you are dialyzing the patient for up to 4 hours, then you will get a very adequate convective clearance of 23 liters in one session. So to conclude, so this is a simplified diagram which is used in hemodiafiltration. So the standard dialysis fluid is generated by the machine using the concentrate and the RO water. It runs through a balancing system. Then it runs through the first dialysate filter. It generates ultra pure water and it goes through the infusate filter. This filter can be either before the pump or after the pump. Then there is an infusate pump, and part of the ultra pure water that is generated goes into the hemodiafilter, where it is used for dialysis, and the blood is taken from the patient's body. It goes through the blood pump. It runs through the dialyzer. Then the infusate is infused back into the patient's blood. So the infusate rate varies from depending upon the your targets. So what is the target that you have selected? It also depends on the body surface area. So in a patient with a low body surface area, you need not remove 23 liters in each session. So you'll have to target based on the body surface area also. Now, the returning fluid, the effluent fluid is again run through the balancing chamber, and the balancing chamber decides the amount of the fluid that is the ultrafiltration part of it, and in this patient around 5 ml per minute is removed. So this is a simplified version of the hemodiafilter diagram, the blood compartment as well as a dialysate part. So the main teaching points are, so the main determinants of convection volume are treatment time and the blood flow rate. So you have to optimize the treatment time to at least 4 hours. You have to keep the blood flow rate of 400 ml per minute. And you can go up to a filtration fraction of up to 30%. For an optimal blood flow, you have to use a 14 gauge needle or a 15 gauge needle. Then you have to increase the standard dose of coagulation by 10 to 25%. And you have to choose your hemodialysis membrane with a surface area more than 2 meters square. The short capillary should be used to prevent back filtration. You have to use a high KU of more than 55 and an appropriate capillary diameter more than 200. So these are the general requisites. So the key components for implementing a successful hemodiafiltration program is you should have a good water treatment and a delivery system. The staff should be adequately trained for all these procedures. Then the vascular access should be very good, and it should deliver a blood flow of 350 to 400 ml per minute. So the survival of your patients on this particular procedure will be markedly improved by the application of hemodiafiltration. Now, the major limiting factors in our country would be the cost of the procedure. In general, it is done in all our metro cities. In general, the cost is around 500 to 1000 extra than that of a conventional dialysis that we perform. And you should have a very good water treatment system. So thank you. Thank you, Vilesh, for moderating the session.